Hello, and thanks to those who are tuning in to a chat with the American Association of Orthopedic Surgeons. We're really excited today to have Dr. Barber and Dr. Page here to talk about some of the changes that are happening in healthcare, and specifically bundled payments and electronic health records. So if you guys want to maybe just give a little bit of an introduction.
Hi, I'm Dr. Tom Barber. I'm an orthopedic surgeon in Oakland, California, and I'm the chair of the Council on Advocacy for the Academy of Orthopedic Surgery and the Association of Orthopedic Surgery.
I'm Alexe. I'm an orthopedic surgeon in San Diego. I chair the AAOS's Healthcare Systems Committee, and we've had a great day here on the Hill. Wouldn't you say, Tom?
Absolutely, it's been fantastic, and we've been able to educate lawmakers on some of the changes that are coming down from Medicare, and educate them as well on some of the impacts of the new legislation on healthcare delivery.
I think things kind of started, as everyone remembers, back in April. We were so excited to finally see the end of the SGR, and with that came MACRA. And we knew at that time that MACRA, which is basically our new laws on the Medicare funding, left a lot up to what was going to happen in the regulatory arena. So that was going to be a series of rules that might come from CMS. And so what we really had back on July 28th was the first of those big rules that affected orthopedic surgeons, and that was the comprehensive care for joint replacements. And it was basically a way of mandating bundled payments for total joint replacements. Tom, do you want to tell a little bit about that?
Absolutely. Yeah, this is a proposed rule from Medicare that mandates bundled payments for total joint replacement in about a third of the markets in the United States. And they've been chosen randomly, 75 health system areas, and it requires mandatory bundled payments. And what that means is that the payment for total joint replacement includes the hospital payment, the payment to physicians, as well as the payment to post-acute facilities such as skilled nursing facilities and home health. And this is all put together into one bundled payment. This is a new way of paying for these kinds of procedures, and there are lots of technical details that are both exciting and concerning about this new proposal. And I think as an association we are very excited about the potential of new payment models, but we're concerned about some of the details in this particular proposal, and we have submitted comments to Medicare and to CMS so that they understand our concerns and will hopefully address them before the final rule is released on November 1st. So we're waiting now for that final release. And then we've got also some of our own alternative payment modules that we're looking at. And Alexa, why don't you explain sort of what we're doing as far as the MACRA legislation and what that means for us?
I think it's very important when we think about this this new mandatory bundled payment model that CMS has a proposed rule for. It's important to recognize that bundled payments are not new to orthopedic surgeons. It's something we've been doing for many years, and that we have a lot of interest in. We want this to work. We think bundled payments can be a very good way in which to provide care for a very distinct procedure like a total joint replacement. This has been happening earlier with some of the CMMI, the Center for Medicare and Medicaid Innovation, particularly with their Bundled Payment for Care initiative, the BPCI. And some of our orthopedic surgeons have been involved with that, even going back before that, with trying to work with their hospitals, work with other providers to think about a joint replacement, not just as a piecemeal from the office visit to the joint replacement and the parts that come into the operating room and the physical therapy afterwards, and then the visits after surgery and the physical therapy, but really providing that as all one group. And that's what the bundled payment means. That's something that as MACRA, and that's our new way in which we're going to be paid through CMS, is one of the ways they're trying to go through these alternative payment models. So when we think of alternative payment models, that's as an alternative to fee-for-service. And among those alternative payment models, it includes bundled payments, which is one very amenable to orthopedic surgeons. The other ones include patient-centered medical homes, initiatives like that, and the ACOs, the Accountable Care Organizations. And of those three, we as orthopedic surgeons have really found a place in bundled payments. And one of the things that we found is that it's a system that works so well. It's not just for Medicare patients. Many orthopedic surgeons are involved in commercial bundles, and these are the payers. It can be insurance companies, it can be self-funded employers, but they recognize that a bundled payment, sort of saying, this is how much is a good price for a total joint replacement, and offering that and allowing the physician to say, what should be covered there? How can I derive the best value, is a very powerful way to get that treatment for the patient. As physicians, what we do is we understand not just the technicalities of how to put that implant in, but more importantly, what parts are value added, what do our patients need, and by the same token, what don't they need? And with other payers, we've developed ways in which we can really help to manage that from start to finish. And I think that's one of the most powerful things that we as orthopedic surgeons can offer. So I don't know if you want to go with that.
I just want to just expand a little bit, is that really what we're looking for is the best value for patients. And value is defined essentially as benefit divided by cost. So as you increase the benefit, you reduce the actual cost for that benefit. And I think that the big thing here that we need to understand is, as we work together cooperatively with hospitals and with other physician groups and with skilled nursing facilities, we can actually improve the quality of care at the same time that we're reducing the cost. And that's really important to all of our Medicare beneficiaries throughout the country to see that happen. But in order for that to happen, it really has to be done in a way that physicians can control some of the decision making, so that we can be sure that the quality is the best it can be. And we need to make sure that the details are such that we're, for instance, tracking the right quality outcomes, so that we make sure that we're trying to improve the care overall and not just watching cost. And that's a really critical issue. And I think, we could talk a lot more about the details, but I think one of the things we wanted to do is give people a chance to ask some questions about this. We could certainly go on, but do you want to open it up for some questions at this point?
Yeah, sure. Does anyone in the room have questions? If not, I can go to some that are online. You've been talking a little bit about the difference, like bundle payments generally for orthopedics and how that has worked. Could you maybe expand on some of the challenges with the mandatory bundle payment proposal?
Sure, absolutely. Let's talk first about what's worked, just so everybody sort of understands. Where this has worked, there have been some innovation projects with Medicare through BCPI, which has allowed bundled payments that are mostly controlled by physician groups or a collaboration that's a tight collaboration between hospital and physician groups. And some of those initiatives have worked very, very well, but we don't have the full results from those yet because all the results are not in. And that's number one. Number two is there have been a number of places where private groups or private insurers have created bundles. For instance, with the Rothman Institute in Pennsylvania, and other areas where there have been private bundles that have been created that both improve quality and reduce cost. And that's been very successful in a lot of different markets for both Medicare patients as well as non-Medicare patients. And the success that we've seen have been when physicians drive the process and they're very engaged. One of the things you have to all understand is that 80% of the decision making around a patient who has a total joint replacement is done by the clinician, by the physician, okay? And so we really control, for the most part, the quality as well as the cost of any particular episode of total joint replacement. So it's important to understand. And some of the problems that we see with this present proposal from Medicare is, number one is the timing. We're being asked to prepare for a bundled payment in a mandatory fashion in a third of the total joint replacements done in the United States within 2 months. The rule is going to be released on November 1st, and they expect full enrollment by January 1st. That's problematic because there's not enough infrastructure in place, people understanding to be able to implement something January 1st that will actually improve quality and reduce cost. It's going to be very difficult to do. And yeah, go ahead.
I think that part of what Tom speaks to is we think about those examples where we have done very well and what we have learned effectively as orthopedic surgeons doing bundled payments prior to this is that physicians have a lot to offer to building these, and I would say that the way CCGR is structured right now, that physicians don't have enough of an ability to add their knowledge base, their experience to managing this bundled payment for the total joint replacement. And you alluded to that 2-month period. Most hospitals, because this is mandatory, there's no preparation, no background for these hospitals to handle the completely new idea in most cases of bundled payment. And we're seeing that perhaps some time for CMS and orthopedics to really work together and let us both bring our best to the table. Could be a big changer, really a game changer.
Collaboration, we've seen again and again in medicine, is what really leads to great success, both in quality of care as well as in reducing costs. And we're asking for a time period to really collaborate with CMS, sit down at the table and help design this in a way that will be best for patients, for our Medicare recipients nationwide. We know we can do this. We've done it in many different venues around the country. We've done it successfully, and we know we can do it in this case as well, but we need to sit down and partner with them and really understand what we can do. I'll give you some simple examples where collaboration has worked very well. One is when we've worked with CMS and we've worked with AHIP, which is the American Association of Health Insurance Plans, to develop metrics around total hip replacement, quality metrics that we would follow. We've actually been able to identify 3 good quality metrics that we all agree should be followed for total joint replacement. That's great news. That's wonderful. However, as CMS has implemented them in the most recent bundle proposal, they have said that you cannot participate in the upside, in other words, additional payments for good quality, if you don't meet the standards on 3 quality metrics. Each of these quality metrics independently are important, but CMS is saying that you have to be better than 30th percentile in each of 3 measures. That basically eliminates about 50% of hospitals in the United States from ever getting an upside payment, even before they start. And some of the metrics, while important, such as HCAHPS, which is a patient satisfaction with a hospital, are highly influenced, for instance, by the physical plant that you're in. If you're in an older hospital, you may have a lower HCAHPS score. And we believe that there ought to be some partial credit for, say, getting 2 out of 3 of the quality metrics so that you can actually get some upside payment, even though we understand that we want to encourage every hospital and every physician to strive to meet all of those quality metrics. It also has to be a fair playing field so that we can actually get there.
And that reminds me of another one of the concerns that I think we have, which are the unintended consequences. Certainly CMS wants to make sure that we're continue to able to provide the care needed to all of our seniors, regardless of what their healthcare status is. And one of the problems that we as physicians, I think, see right now with how it's structured is that CCGR does not allow for any risk stratification, and that's the process where we can identify those patients that we know are not going to do as well. And some patients will do fine, the younger, the healthier, ones who don't have any other medical problems. But when we think about the patients who often really need the surgery the most, those can be our older patients, our more frail, the ones who have diabetes, high blood pressure, often don't have the resources they need at home. These are often patients who are most affected by disparities. And by giving a set price, you are inadvertently really going to try and keep hospitals from not wanting to have those patients because they'll be more expensive. And it's worrisome that until you can find a way to say, yes, we know this patient who has high blood pressure, is a diabetic, is 80 instead of 67, that patient is going to do worse, but we recognize that, and therefore we're willing to see that as a different patient and pay accordingly. That's something that can allow the hospitals to not discriminate against those patients who may need the surgery as much or even more. So risk stratification I see as a big part that's missing here.
I agree with you 100%, because that can lead to cherry picking. And by cherry picking, I mean the hospital's choosing only those patients who are ideal to have the procedure that won't have complications. And I'll just give you a quick example of that. Our heavier patients, those patients that are overweight, they are known to have a higher complication rate. We know that, and many of them need to have weight reduction before they have surgery. We also understand that, but there are also those patients that really need the surgery despite being overweight, and we'd hate to see them discriminated against because of their weight as a single factor. Obviously, it needs to be taken into account their entire health history, and it's not just that one factor. But we don't want patients discriminated against because of those factors.
One of the other things that, as we think about our experience as orthopedic surgeons with bundled care, one of the aspects that's really made bundled payments more effective is as we've moved ahead in the infrastructure, the technology that enables all parts of care. We talk about everything from the first time you see your orthopedic surgeon in the outpatient through getting your pre-op evaluation, the operating room, if you need to go to someplace after the hospitalization when you've recovered, and what we call that post-acute care. The ability to have communication and that infrastructure for all those pieces to come together is what's made some of these other models and some of the commercial models effective. Yeah, I think one of the concerns with having just those 2 months right now between the final rule on November 1st and going into effect on January 1st is that that infrastructure isn't there, and that really speaks to another problem. I wonder, Tom, could you elaborate more on that?
Yeah, I want to talk, if I could just change gears just a little bit to talk about what the bundle actually covers, because I think that's really illustrative as far as what the potential problems are. The bundle as set up under this comprehensive care for joint replacement program from Medicare essentially just covers, just allows you to manipulate, I should say, the post-acute care. So while the dollars cover the hospitalization, the anesthesia, the surgeon fee, all those kinds of things wrapped together, as well as the post-acute care, the only variable that's really under control is going to be the post-acute care, whether the patient goes to a skilled nursing facility or not. Because Medicare in the document about the bundle specifically excludes relationships between the doctor and the hospital to manage things such as length of stay, quality of care in the hospital, or prosthetic cost. So a lot of the management of the case is really not possible under this bundle. And that's problematic because it's focusing only on one small aspect that, yes, is a significant cost, but it's only the skilled nursing facility after discharge. And we think it could be far more and be far more valuable if it included more.
And I think that speaks back to the fact that when we talk about the broader area, those are areas in which the orthopedic surgeons really have the experience to understand where we can save money and where we need to spend money, because that's really what value is. And clearly we want to have the precious healthcare dollars spent in a way that are going to be most effective. So I see that as really key. I wonder if we have any questions.
Yeah, could you talk specifically, you mentioned the infrastructure, could you talk specifically about electronic health records and some of the challenges that are being faced there, maybe the legislation?
Yeah, let me talk a little bit about that. One of the challenges is the different sites of care and whether the electronic medical record is portable across those sites of care. So, for instance, the doctor's office might have a different electronic medical record than the hospital, which might have a different record altogether than the home health agency or the skilled nursing facility that the patient goes to. So it's very difficult to maintain continuity of care if you have different systems across, because the interoperability of those systems is not good. And so we can't necessarily get information from the skilled nursing facility to the doctor's office because those systems don't talk to one another. So that's something that could be greatly improved. And I think that there are a couple other factors here that have to do with meaningful use and how we actually implement IT systems in healthcare. We do have a program from Medicare which is meant to encourage physicians to adopt electronic medical records. A wonderful goal. The problem is that it is defined in such precise terms that it doesn't apply to all of medicine. And we would encourage Medicare to start thinking about meaningful use as a specialty, because there are some things that are really applicable to one specialty, say orthopedic surgery, that might not be applicable to pediatrics, for instance, and vice versa. And so, when you're seeing a young teenager who sprained their ankle at age 12, Do you really need their full smoking history, for instance? Do you need some other things? Maybe, maybe not, but that's required by the meaningful use criteria. So there are ways where we could work together to really have a more meaningful use criteria. And I think we'd encourage that and hope that that CMS can listen to our concerns and allow us to do things. If you look at the data, one of our concerns is 75% of all orthopedic surgery practices have an electronic medical record. That's great. That's wonderful that we have it, but only about a quarter to a third have actually achieved meaningful use. And you wonder why, because all of these electronic medical records that have been purchased are capable of having meaningful use. But the problem is that some of the criteria to meet meaningful use are so stringent that we can't actually meet them. And I'll give you one small example. Under Meaningful Use 2, patients have to use a patient portal to send messages to a physician. Great goal, fantastic goal. The problem is that when we make those portals available to patients, they don't always use them. Okay, so we have many instances where physicians have noted that to qualify for meaningful use, 10% of their patients have to actually message them. But when they haven't, doctors actually have to hire staff to work with their patients in the waiting room to message them just so that they can meet meaningful use criteria, because the patients aren't doing it on their own. And that's a concern. Why would we hire people just to meet a metric? That makes no sense.
So I think that does also come into part of how we can work to get that more effective, not only for office visits, but for the whole continuum of care. And these are all things we know that CMS, everybody's working towards. We're just not there yet. And another year may be time in which these will move forward, as well as the ability to collaborate with CMS and get to something more successful. I think we really want this program to succeed, wouldn't you say, Tom?
We absolutely do, and we need a little bit more time.
Yeah.
We need to sit down at the table with CMS, and we've got to really hash this out and make this a valuable program for everybody in the United States.
Do we have other questions?
Yeah, just to follow up with two questions on the issue of time. So I understand that 2 months is very short, but I'm curious, what time do you think would be appropriate, would be more appropriate, would be adequate? And then following that, given that orthopedic surgeons do have experience with bundle payments and alternate payment models, do you think that the 2017 timeframe to start the MIPS program is really relevant and appropriate for other specialties who may not have the same experience that orthopedic surgeons face?
I would say we think at least a year is what we would want for this, and part of that would be a commitment on both sides that in that year we're committed to work together, that it's not just a year of waiting and treading water, but instead clear, defined goals that we would move ahead with. When you speak towards where we are, so when we think of MACRA, there are really two different pathways. You've got the MIPS pathway that I think has a lot of benefit in terms of replacing the piecemeal way in which we would have had to have gone with PQRS, meaningful use, although meaningful use is still part of it, the value-based modifier, and the different reporting. So this is now one unified because it represents, I think, an improvement from where the SGR had us and where previous reporting was. But the alternative payment models is another one, and orthopedic surgeons have experience in the bundled payments. For other specialties, you have the ACOs, the patient-centered medical homes, that are more amenable. There are some that are procedure-based. Cardiology has a lot of experience. There's other surgical subspecialties. I think we're all working towards seeing bundles as something potentially larger, like even a diagnosis, but we recognize that that's far away.
I'd like to follow up a little bit on that, because yes, we do have experience in many pockets, but not all orthopedic surgeons have experience with bundled payments. One of our concerns is that those physicians and practices that are very comfortable with bundled payments have been voluntarily part of the CMS, CMMI pilot projects, which were under BCPI. So they have all committed to that already, and they are excluded from the bundle that's coming up. So all the people that know anything about it are now excluded from the bundle that has been proposed as of January. Okay, so that's sort of concerning in and of itself. and the fact that we don't have the information published from those people that know what they're doing for everybody else to follow at this point. And so we're waiting for that. So that's point number one. Point number two is that there's several parts in preparing for MIPS that are important, okay? Part number one is development of the quality metrics and the resource-based metrics that are needed for the program. Those metrics have to be developed by Medicare, not by Medicare, but chosen by Medicare by November 1st of 2016. That leaves us very little time to develop the metrics. And one of the things you should understand is Medicare has said they highly prefer metrics that are approved by NQF, the National Quality Forum. So the problem is that to get approval through NQF is a 4-year process. And so that's great. The legislation was passed, 6 months ago, and now we're being asked to develop new quality metrics that will be applicable and in place by November of 2016. That doesn't give us enough time to actually put it through NQF and approval. So while Medicare has said they're willing to accept proposals of other types of metrics, they have said they highly prefer NQF ones. So we're moving very, very quickly. In the Academy of Orthopaedic Surgery, we now have a performance metrics committee that has been well funded to review these performance metrics and really move forward. But the metrics are expensive to develop, they're difficult to develop, and they take time. So even with a fully functioning performance metrics committee for over a year, we haven't been able to develop more than a couple of performance metrics, and they're just in process. They're not even completed.
I think it's also good to understand why Dr. Barber is so feels these measures are so important, because the underlying part of this is that if you don't provide high quality care when you're getting a certain payment amount, you could say, oh, well, we just won't do this, or we won't do that, no one will ever know. Well, yes, the patient will know, the quality will suffer. And that's really what it comes down to, is that these the value is intrinsic in looking that the quality is maintained. So in order to be able to assess the quality, you have to have those measures. And I think that's really why we want to make sure that we have good ways to measure whether a patient is getting the care they needed, and after they've had that joint replacement, are they happy? Has it really changed their life? Has it given them meaningful improvement? And in order to make that decision, we have to know that we have the measures that adequately reflect that and have that built into part of that. That's inherent in MIPS, that's inherent in all of the alternative payment models. So that's a foundation.
And just to expand a little bit as far as your question, as far as other specialty societies, our sense is that the Academy of Orthopaedic Surgery is actually far ahead of many other specialty societies. And that's a real concern, because we're terrified about the time frame and the ability to develop these metrics. I don't know how other societies that haven't gotten as far as we've gotten, who haven't developed the performance metrics committees and don't have the funding for these things, are going to develop them. And we did hear 2-3 weeks ago at an open hearing of the FDA, a CMS staffer state that she thought that a delay in MIPS implementation was going to have to happen because they didn't think CMS was going to be ready. Now, whether they were speaking for all of CMS or not, I don't know, but we have heard that from some staffers at CMS.
So lots of different moving parts, a lot of challenges, whether you're looking at the alternative payment models and the bundled payments within that, or certainly at MIPS. A lot of that coming down to the ability to measure effect, to know that we're measuring the right thing. Then how do we get those measures done? How do we get them reported to CMS so that they know we're doing the quality work? So many different moving parts, and we're certainly there and hoping to work as closely as we can with CMS, I think, to get those things together.
And I think it's important to recognize that we're working with CMS in multiple ways, and I think every specialty society should be doing the same. For instance, we're meeting with the quality measurement people from CMS on a quarterly basis for the last 2 years, trying to understand their perspectives and what we need to do and what we should be doing. We also have something called the Orthopaedic Quality Institute, which is going to happen in November this year and happens in November every year, where we bring together regulators, payers, and orthopedic surgical leaders to really discuss the issues that are facing us and try to decide where we're going. This year's focus in November is going to be on patient-reported outcomes and how we apply those to payment models and whether they can be applied to payment models. So there will be some interesting discussion there. And we'll certainly have CMS at the table as well as other payers such as Blue Cross and others that are there to comment. And we'll have lots of good discussion, so it's important.
Were there other questions? Anything more we could answer? Any questions from online?
I have one. Could you give us some examples of meaningful use measures that would be beneficial for patient care?
Mm-hmm. Absolutely. I think that there are a couple of meaningful use measures that are in place that we might agree with. For instance, smoking history, making sure that we know whether a patient smokes before they have surgery is sort of a critical factor, because smokers actually have a higher rate of complications with surgical procedures, particularly total joint replacement if we're talking about that. So that could be a meaningful use. I think that
medication reconciliation is another important one. It's surprising how many patients don't know what medications they're on, and part of meaningful use is being able to at every visit make sure that both the clinician and the patient know what medications they're on.
The other thing I think that hasn't been talked about enough, or hasn't been talked about in a way that's easily interpretable, I would like to say, because it's usually talked about in IT terms that people don't understand, is interoperability. What does that mean to a practicing clinician? And I think, to me as a practicing clinician, interoperability means that I can read notes that were written in another EMR system. The VA has something called blue button technology, which is nice. They can push one button and the electronic medical record can print out and send electronically a summary of the medical record, so that a clinician can then understand what's happened to a patient and actually read it. It's so simple. It's not true interoperability that people are seeking on Capitol Hill when they talk about having all the records easily transferred from one system to another, but it's enough that clinicians can actually read and understand the issues that have occurred in other venues. You could see the same thing happening, say, with a skilled nursing facility. If their EMR could produce a summary of what's happened at the skilled nursing facility and send it to the clinician so I can actually look at it, wouldn't that be marvelous? And yet it's a very simple thing. But we always focus on sort of the nirvana, where everything is fully integrated on one network. I would venture to say that while that is a great goal, that is something that is not readily achieved, for instance, by cellular phone networks in the United States, because you can't go everywhere and always get a signal, for instance. But many places you can. And so I would say that, as we're looking at some of these things, interoperability needs to be a staged affair, and it needs to be a combined effort. There ought to be those things that are there for clinicians to understand what's happening with their patients, those things that are there so that we can have population management, and those things that are there that are for some of the more technical things like payments and billing, where you can actually merge some of the demographics and insurance information, some of those things, which are probably in some ways less important than the clinical aspects. I know it's a long-winded answer, but sorry. I hope to be not quite so technical. But
I think it's something we've known you have a lot of interest, a lot of knowledge, and a heck of a lot of passion about.
Yes, indeed. Okay.
Going off of that, do you think we'll see improvements soon? Is legislation required? What do you think the next steps might be?
We will absolutely see improvement. One of the improvements is I think all of the EMR companies are working on sort of summaries and ways to transmit information from one system to another. And there have been several pilot projects, say, between the VA and Epic, or Kaiser and Epic and Cerner, to try to understand whether there can be some transmitting of information back and forth. My own bias is there hasn't been enough focus on what is actually clinically needed for that transfer. And I know one example in our system that worked very well was we developed a USB-based stick that was a personal portable medical record. So patients could actually go in and for $5 get a USB stick that had their personal medical record on it, and their last cardiogram and their last chest x-ray, so they could take it with them, and anybody anywhere in the world could read it as a PDF off of their USB stick. And that's the kind of thing that we can develop and is more regulatory based, because the government could require a summary in some electronic fashion to be produced by every electronic medical record. They haven't gone there yet because of resistance from manufacturers of these record systems. And I think that's a shame, because us as clinicians, we want to be able to read the records of our patients, and we're not there yet. So yes, I think that this will improve with time. If I look into the future 20 years from now, I think we will have solved these issues, but in the next 20 years, there's going to be a lot of pain and difficulty in getting there. It's not an overnight solution, no matter how much money you spend, because each of these electronic medical record vendors have their own proprietary standards, and it's going to be very difficult to integrate all these together. And so it's going back to the Betamax or some of the other things. When you try to merge all these things together, sometimes it works and sometimes it doesn't. And I think that we need to continue to forge a pathway for interoperability, but it's going to be a slow one, and we have to probably have interim steps that we take along the road.
If there are no questions, I think I would summarize just by saying we appreciated having the proposed rule and a chance to comment on it. We appreciated having the day-to-day to take it to the Hill and speak with our lawmakers on where we saw the positive change, and it had some great feedback showing that there's interest in what we have, and hopefully this will be something that we can really move forward with enough time to make it a success.
Yeah, I mean, I think that there's great possibility for success. I was actually encouraged with our visits to the Hill today. We were able to meet with Republican and Democratic staffers, and I think we got the message across. I think they understand what's really happening with the Medicare proposal for bundled payments and total joint replacement. And I think they also understand the concerns and issues around electronic medical records and how they merge together, because they really are in some ways conjoined as far as some of the issues that occur with sites of care and that kind of thing. So I hope that both in Congress and here today we've been able to explain some of the issues that we see and some of the possibilities and some of the future state, if you will, about where things are going to go and how we can improve care at lower cost.
Thank you.